Dr. Sanjai Sinha, it's wonderful to have you here. Thank you for joining. How are things in New York?
Lovely. A beautiful day. Can't complain. Thank you so much for having me. It's a real delight to be here.
So Sanjay is an associate professor of clinical medicine at the Mount Sinai School of Medicine in New York. He's been seeing patients as an attending physician for nearly 25 years in New York. He's seen thousands of patients, right? You do a lot of teaching for med students and, of course, for residents. And you worked on all aspects of primary care and quality improvement. So really excited to have this conversation with you about primary care and longevity.
Thank you so much. Yeah, I've really run the gamut and seen every kind of New Yorker I think there is in the past 25 years. And, I've always loved being someone's doctor, if you will. When people refer to their doctor, they're usually talking about their primary care physician, coaching them, learning from them, really trying to understand how to meet them where they're at to help prevent medical problems and manage the ones that they might have.
Let's start with a little bit of context about primary care, because I think it means different things to different people. And of course, it's starting to change. So just briefly, what is primary care and how has it changed over time?
Wow, that's a big question. I do think, primary care is something that everyone should have. It's, as I had mentioned, the first place that you go to for all medical information and medical care. If you're a child, it's a pediatrician or maybe a family medical doctor. If you're an adult, it's usually an internal medicine doctor. Some women use their OBGYN as their primary care provider. So these traditionally have been sort of the primary care practices. But I think as time has evolved and more people have become aware that they want to start taking care of themselves sooner, there's been more of a need. And there's a variety of things we're going to get into about chronic conditions and medical problems that have, gradually occurred over the last several generations that have made access to primary care that much more important because people are having medical problems earlier and earlier in their lives. And so when you think of who do I call when I have a need, usually the first person you call is your primary care doctor. In other countries, or even in this country, sometimes we're referred to as GPs, general practitioners. But I think with so many advances in medicine over the past several generations, the power of diagnosis and treatment and advice and counseling have really expanded the role of primary care, so much so that, we really are the quarterbacks of all of care worldwide, but, I'll speak for what I know about in the US. So I think it's massively important. And I personally think, having a primary care doctor as a right or having healthcare access as a right would be a wonderful thing if we could somehow make that happen. But short of that, we want to have a discussion about how important primary care is today and some of the challenges are.
You mentioned something interesting, a GP and general practitioner, and we've talked about primary care physicians. Now, I trained in the UK where the two were the same thing. And it seems like in the US, a primary care physician can be a specialist where it's actually, this is your primary specialty and you essentially serve as my GP, plus you have your specialty area. So if you're a child, it's a pediatrician. You're kind of the GP, but you have a specialty in pediatrics. For women's health, it might be an OBGYN. Can you talk a bit more about that, about what is a GP versus a primary care physician?
Great. Yeah, I understand the terms can be very confusing. Internal medicine, an internist would be the corollary to your comment about the specialty within primary care that is really adult general medicine. And so my specialty is internal medicine. I believe GP is a term that probably came out of the UK. And I think a lot of people in this country use them interchangeably, GP and PCP. So one other wrinkle that's become an interesting augmentation of the term in the past, I'd say 25, 30 years, is primary care physician has often been converted to primary care provider because there are now certain non-MDs that provide primary care, like nurse practitioners, even some physician assistants, at least in the United States. And state by state, there's different rules as to the kind of supervision they may need and what their scopes of practice are. So just to complicate the question even more, there are different kinds of PCPs, but traditionally primary care physicians are internists who take care of adults 18 and older. We do a residency after medical school in the US. That's typically 3 years at a minimum for internal medicine. And then we can start practicing after getting licenses and board certifications. Some people will go on to do subspecialties after internal medicine, like cardiology, pulmonary, GI, rheumatology, infectious disease, and can serve as, again, further complicate this, serve as a subspecialist as well as primary care if they so choose to do that. Did I confuse everyone enough yet?
Yeah, there you go, right? So as a patient, as a member of the public, you're thinking, okay, who do I need to see? What specialty? So when I moved here, the second time I moved here, obviously I've lived here twice, it was unclear to me, okay, I have health insurance that allows me to go directly to a specialist. Now, as a medical professional, I can figure out for my own needs which specialty I need to go to. but most people can't. They're not going to know for sure. This quarterback model that you mentioned, which, I'll talk about the NHS probably quite a few times when it comes to this model because it's been replicated all over the world. It is the basis for the NHS model, which is that you go to see your primary care physician first. They will then triage you to a specialist. They'll send you to a specialist if needed, but they will try to manage your overall care over time, and they will know you best because you'll go to a specialist for something, then you'll come back to them and they will continue to be the overarching person who looks after your care. How often do we see that quarterback role being played here in the US? And if people are listening to this thinking, I don't know if I have a quarterback for my care, what would you say to them?
You need a quarterback for your care. You can't win a game without a quarterback, right? For those football fans out there. So I think that there was a lot to what you just said that could require days or hours at least of conversation. I'd say first and foremost, because of what I had mentioned earlier, our ability to diagnose, to treat has really expanded as internists, as primary care physicians, because of both the wonderful dissemination of information since the dawn of the internet, as well as a lot of great sharing of best practices quickly, therapeutic advances, things that can be done in the office with us. So to sort of answer one of your questions, we don't have to necessarily refer to a specialist just because a patient, a consumer thinks they need a specialist. Part of our job as a quarterback or coordinator is to determine, hey, let me see if I can figure this out for you myself. And if I can, I'll save you a visit, we'll save time, we'll save costs, and hopefully fix your problem. If we can't do that, then yes, we can refer to a subspecialist, a specialist as needed. I think part of the evolution of this kind of coordination of care really came out of the insurance industry and policymakers probably in the 90s, I would say, 1990s in the United States, where there was some terminology used like gatekeeper, things that were not super popular. But the idea was that, hey, instead of having a patient, like you said, who's non-medical, who may not know who they need to see, deciding on their own and therefore maybe driving up costs, because we know that costs tend to be a little bit higher when that patient goes to a specialist, a subspecialist outside of their primary care doctor. Instead of doing that, why don't we have everything run through the primary care doctor, which of course, has its other issues because there's bottlenecks. And so I think there's more of a middle road between those two where depending on the insurance plan, and there's lots of different insurance plans in the United States, there's different models as to whether or not you have to see your primary care doctor first, or you can go right to a subspecialist, or certain medications or certain imaging or other testing has to be ordered by the primary care doctor. So there's all kinds of different combinations of these things that can occur because we have this complicated three-party system. We've got the doctor, the patient, and then the payer, whether it be the insurance company or the government.
And if I think about how primary care has changed over time and is continuing to change, we've got back in the day, it was your family physician who lived down the road, who knew you and your family really well. They look after you, your kids, your grandkids, and so on and so forth. Now, that model has changed quite a bit over time. There's been a lot of consolidation, which basically means these small primary care shops have become bigger primary care centers, seeing lots more patients. And we've seen this emergence in the last few years, in particular, of technology, virtual care, telemedicine, these sorts of things, which have been great for basic access. But healthcare has become that much more transactional, where you don't necessarily know the physician you're speaking to, but you might be able to, quote unquote, get what you need. And that might just be hey, this is my problem. Okay, here's a prescription. Bye. I'm never going to see you again. And that runs the business almost, right? How is primary care changing today with that in mind?
Great question. I do think that the transactional nature, the on-demand nature of retail consumers, as it were, the two of us are retail consumers. Everything we consume, everything we do, if we can do it quickly, efficiently from our bedroom, we would love to do that. And to some degree, I think healthcare consumption is no different, either through how people get information or how they get care. And of course, there's lots and lots of problems, right? This just adds to, we already had so much fragmentation of healthcare in this country where if, you don't hew to the model that we used to have, where your primary care doctor really gets to know you longitudinally, much less your family, then all the context is gone, right? All the context of this patient's physical trajectory in life, their emotional stability, their family history, all these things are very infrequently asked about, touched on. Here's your medication, here's your test, see you later. And then there's redundancies in care. There's all kinds of, fragmentation. So I think that there are a million problems that can unintentionally sprout from the current systems that exist. Now, to your point about, telemedicine and access, it's a tension that we have to live with. We would love to have access for everyone. And particularly, say, in rural areas or areas where there are very low density of doctors, it's a must. And it's wonderful if you can get the care that you need always. We talked about delivering the right care to the right person at the right time, the right cost, hopefully. But what does that mean long term? What's the long view for that patient? When we think about longevity and we think about chronic conditions and health, if you have multiple different people touching your medical care that have no vested interest in getting to know you or anything about you, and likewise, the patient or consumer doesn't have any interest, where does that leave us? It leaves us with very little information about your trajectory, about what you really could need. And this is why everyone should really have a primary care doctor. There's lots of data, decades of data that suggest people with a regular source of primary care get hospitalized less, die less frequently, have less chronic conditions that are uncontrolled. There's actually good health equity, right? Even when these studies look at all these outcomes, these great medical outcomes across different ethnicities and different income strata, that there's an improvement. So there's clearly data to support the value of having one place to go for your care. Question is, do you have that place? How can you get in to see a primary care doctor when there aren't enough of us, or we're all full, things of that nature?
I want to quote a couple of stats that are concerning when it comes to primary care from the Health Resources and Services Administration, the Association of American Medical Colleges. We are short of PCPs or primary care physicians by about 13,000 as of now. Now, in a decade, it's going to be 40,000. And this is the stat that really hit me. Around 100 million people, so about a third of the US population, is in a primary care shortage area. And this is particularly bad in rural areas. So there's a gap for primary care. And in part, this is where the opportunity, I think, has been seen by technology companies and startups and entrepreneurs. And that's where telemedicine is trying to fill a gap. But there's clearly a gap in primary care here, and that gap is only going to continue to widen. Why is that? Why is it that primary care is not prioritized more here, despite the evidence, which we'll come back to, because that deserves its own conversation, I think?
Well, if I had to boil it down to one thing, it's probably reimbursement. If the reimbursement gaps exist between primary care going into internal medicine or family medicine, say, or pediatrics versus going into radiology or anesthesiology or one of the surgical subspecialties, more and more people are going to see that as a reason not to go into primary care. The amount of work that we have to do, dare I say, bureaucracy, the amount of paperwork, the amount of arguing with insurance companies and coordinating care across multiple subspecialists all falls on us. And so it's a lot of work. The pay is lower. And since the advent of electronic medical record, the frustrations that we all have, I got to say, the hardest part about being a doctor for me on a daily basis is just figuring out how to manage the electronic medical record when I'm trying to order something. It's not the actual thinking about differential diagnosis, about what's wrong with this patient or what do I need to order. It's how do I order it on this beast of an electronic medical record. I learned it, and then they just changed the update of the software. So there's that. And then the rural nature, the fact that there's such a paucity of primary care physicians or providers in those areas really speaks to where people want to be, sadly. Most of our country, the demographic shifts have moved to urban areas, the last 40, 50 years. It's no different for doctors and their families. And so you have this, migration to cities, urban areas, the cultural norms have changed. People, therefore, would need even more reimbursement or more incentive, however you want to call it, to move to rural areas. So you have these shortages. So yeah, these are just some of the reasons. Medical students every year, I was teaching medical students for a couple decades, and whenever we'd look to see where they were matching for residency, the numbers for those going into primary care generally were shrinking over the years because of many reasons. And one last thing I'll say is so many students in the United States come out with so much medical debt. The average is over $200,000 in medical debt. First thing you're going to look at, for practical purposes, is going to be how much am I going to make as a particular kind of physician? I need to pay off my debt. I need to support my family.
Yeah. And it's interesting because in the UK, when I was training, it was the opposite. Being a GP would allow you to actually make more money in theory, unless you did a lot of private work as a specialist in the hospital. But there are some tensions there as well around the same issues that you mentioned. We'll get back to this conversation in just a moment. But if you're finding this episode helpful, here's a quick ask. Take a second to follow or subscribe to the Health Curve podcast, wherever you're listening. And if someone else in your life would benefit from this episode, or any of the others you've heard, please send it their way. All right, let's get back to it. So let's get to how most people in the US view primary care today. So here we're talking about members of the public. What do you think people experience when it comes to primary care, and what does that result in?
Well, I do think that many people, when they have a good primary care physician, they do feel special because it's so hard to find one because there's fewer of us. And because as the reimbursement rates have been tied more and more to volume, seeing more and more patients, and there's only so many hours in a day, it's become a bit of a, let's just say, not so fun experience when you get rushed in and out of your doctor's office in 15 minutes because they have to keep seeing patients. And so it's become frustrating as much for the doctor as for the patient. So that has been part of the experience for some people. I do think that most people do see the value in having a good doctor that they can turn to. Even people who are very technologically savvy and want to be able to answer everything quickly and on their own, if they have a trusted, and that's a big word, a big important word, trust, a trusted ally in the healthcare system, in the physician, then they see the value in that. But I think that a lot of people are turned off by the fact that they, feel rushed, that half the time that their doctors are spending in the 15 minutes that they have is looking at the computer screen and typing. But on the flip side, physicians have to get that done. Otherwise, many of us write notes for hours, finishing charting, as it were, every night of the week and on the weekends. And since the onset of secure messaging, right, emails via portals, the demands on primary care doctors has gone through the roof. There's so much dissatisfaction and so much burnout because people are pulling at us every which way. They're coming in, they're calling, they're emailing. We still get faxes. We still get snail mail. And that's just from patients, the other doctors, insurance plans, pharmacies, home health agencies, the government, apartment buildings, courts, transportation bureaus. They're all sending us forms to help their patients. So it's a difficult job to have. And sometimes the frustrations, shine through, and people in the public see that as well. But they may not appreciate how hard it is to be a primary care doctor in 2025.
Yeah, absolutely. So, we've talked about these downward trends in the use of traditional primary care and the availability of it, right? What's growing in its place? We've mentioned telemedicine and virtual care, but there's some other stuff that's been springing up to replace or supplement this traditional primary care model, right?
Yeah, for sure. I think that as more and more big business corporations, maybe investment houses, private equity have moved into the healthcare space to try to crack this nut, to fill some of the needs where they see so much demand. I think we've seen an increase in the number of non-physicians, as we were talking about, take care of patients as primary care providers. So they could be nurse practitioners, they could be physician assistants. We've seen retail clinics open up in like Walmarts and CVS and what have you, minute clinics. So there's ownership, of course, One Medical, which got purchased by Amazon. And so there's lots of consolidation, if you will, of areas in the country where there's a need by bigger private industry, I would say, to try and fill in the need. But it's not always with physicians, and it's not always in a model, I would say, that supports what we were talking about earlier, this longitudinal care. So there's some of that. And then there's teledoc and things of that nature, where there are app-based outfits for mental health, for primary care, for weight loss, for all kinds of things that supply licensed professionals, and not all physicians per se, to prescribe medicines and to fill in some of these gaps, at least for acute care. It's harder to know whether, chronic care, whatever, play a role in those kinds of environments.
So at the same time as us seeing these downward trends in the use of primary care, we're seeing a relative surge in interest in longevity, health span, lifespan, etc. So people may have heard of concierge medicine and concierge doctors, which are essentially are higher cost physicians that people can pay to essentially have on call for them at all times to say, you're my primary care physician, I'm going to call you whenever I need, I want really personalized care. So it kind of is what it sounds like, right? It's concierge medicine. Now, there's been this emergence recently, and it's continuing to grow, of what's called direct primary care, which is a version of that, tends to be at lower cost, where people can go to a primary care physician essentially off the street, but it's really online, and say, I want you to be my primary care physician. I'm going to pay you directly. I don't use insurance. And it's like normally a membership-based thing. So like telemedicine that we're seeing, but an actual physician that can try and provide more personalized care for you. And the market that they tend to appeal to is the folks who are getting frustrated with the bottlenecks in the traditional system. They can't get an appointment, they can't be seen for longer than a few minutes, and they want a higher quality of care, and they have the means to pay for it. Can you talk a bit about direct primary care and concierge medicine and where that fits into this whole rubric of options?
Sure. So I totally agree that because of the wait times in particular that patients often feel that they're subjected to in the usual medical care system, that if they have the means and if there is a way to be able to get into the doctor and discuss what they need with their doctor, sort of almost on demand, or at least within a day or two or a week at the most, that's very palatable and it's very understandable. Clearly, a lot of people can't afford these kinds of services, but this is probably been a model that's existed in countries where we've had universal healthcare anyway, where there's a two-tiered system. So I think that ideally everybody would have all consumers, all patients would have the ability to get in touch with their doctors quickly and be seen and have a good longitudinal relationship. I do think the longitudinal relationship, the continuity of care, is the crux there, where it separates this model from, say, a Teladoc or anything that is more of a transactional model. And I got to say, the discussions that we were having about what's replacing primary care in, say, rural areas of the country or parts of the country where there's a supply-demand problem with fewer doctors, they still seem transactional to me on many levels. But these direct primary care models where there's less of a need or really a requirement to see so many patients per day because it's a membership-based practice allows for more time, better quality, for sure, probably, of conversation at least. I want to be careful to say that it doesn't necessarily mean there are better quality outcomes. I definitely don't want to imply that in the direct or concierge care model, but the communication, obviously the lack of wait times are all pluses. Hopefully the continuity are all pluses for this model. Now, as people become more and more burned out, particularly in primary care, I think more and more doctors are going into this model. And so that's increasing supply of doctors who will do that. And therefore, more and more people will see that these things exist. And maybe prices will come down, obviously, because you're increasing the supply. That's a nice consequence, potentially. But then, of course, you're taking some more doctors out of the system for those Americans who wouldn't be able to afford it. So clearly there's a tension there.
Excellent. Really helpful. So why is primary care important? What's the evidence that it works? And what is it really good for?
So if we look back in time and look at lifespan, just in 1970, the average lifespan was 70 years old. And today it's 80 years old, at least in America. And why is this? I think that the identification of a lot of chronic conditions that used to kill people and the management of those things, clearly hypertension, heart disease, diabetes, cancer and cancer prevention, cancer detection, all of these things have helped people live longer. And the majority of these chronic conditions are first picked up by a primary care provider. One of the things that we always learned about in medical school is that hypertension is a silent killer because it doesn't cause any symptoms. And yet probably 50% of people by the age of 40 in the United States have hypertension.
And we have an episode on that. So please listen to it, everyone.
Excellent. And so I think the detection of these chronic conditions, and again, about 200 million Americans have at least one chronic condition, at least one. 6 in 10 younger adults, 8 in 10 people at midlife, and about 90% of older adults. And so who's going to manage these things? Who's going to help you live longer, have more longevity? I think the saying is there's years of your life and then there's life in your years. And the life in your years is the healthspan. Who's going to help you stay well? It's really a primary care doctor. And so there are, as I was mentioning earlier, there are lots of data that look at health outcomes, comparing people with a regular source of primary care versus those without. And in terms of the outcomes, it's sort of unambiguous. There's a decrease in hospitalizations. There's a decrease in emergency room visits. There's improvement in mortality, right? More people live longer with all of these chronic conditions when they have a primary care provider. And regardless of their own background, the patients, this is writ large across all sociodemographic levels. And so the outcomes are quite clear that it's very important to have the input, to have the continuity of care with one doctor who really gets to know you and can both detect and manage and prevent a lot of these conditions.
So the evidence is very clear. Primary care is critical for longevity, health span, and lifespan. We'll come back to that in the next episode that we're going to do together, which is all about primary care and longevity. But before we get there, I just want to ask you one more question about primary care for this episode. And that is, where is primary care going? We talk a lot about trends of what, from an evidence and a scientific perspective, like what is it that the population needs next? And then we talk about these cultural trends of what are people asking for next? And there seems to be this trend towards, okay, people are understanding what longevity, health span, etc. are. In many ways, it's a rebranding of disease prevention. We can talk about that, but this is good. People are starting to understand this is important and are starting to acknowledge more widely that this is what they want. What can primary care do? Whether we're talking about disease prevention as the professionals do, we start to talk about longevity a bit more. What does primary care need to be tomorrow? Where does the field need to go in order to serve what people need and people want?
Well, I think I'm going to sort of calibrate this conversation because we're bursting at the seams. Primary care providers can't do any more than they're already doing, hence the burnout, right? There's too many tasks that we are asked to do that we're responsible for, and there's just not enough time and not enough help. And so from a very simple economic model, you would say we need to increase the supply of primary care physicians or primary care providers. And I think what is likely going to happen. I certainly don't have a crystal ball, but the trends that we see are that more non-traditional medical doctors will fill some of those roles for primary care, particularly in very low supply areas. And in terms of the people paying for this care, be it large employers who are self-insured, be it insurance companies or private equity, or maybe even the government, they all want to save money. And so there's a huge tension there. They don't want to spend any more. And if you're not going to spend any more in terms of reimbursements for physicians, primary care physicians, then you're going to need to find other types of providers to take care of people that potentially cost less. Now, I don't want to open Pandora's box in terms of discussing quality and what have you, but there are lots of studies that look at comparisons of different kinds of providers for acute care conditions and what have you. And so I think that might be part of the future. Whether or not AI is going to actually augment or somehow help assist primary care providers in an efficient way, I think remains to be seen. And, really this starts with policy in America. If the payers of medical care, medical costs don't prioritize paying primary care providers more, then it's going to be a problem. We're not going to have any more increase in supply. And so this continued shortage is going to occur.
Right. And I actually have an interesting stat on this, that the US spends less than 5% of its total health expenditure on primary care. And most will go towards specialty care, hospital-based care, high-cost interventions. Whereas if you look at some other countries where life expectancy is longer, there are lower hospital admissions for preventable conditions, there's better chronic disease management, etc. There is superior health equity. So the differential there, so in the US, it's 5%. Some of these other countries, the Netherlands spends 14%, the UK, 13%, Australia, New Zealand, 12 to 15%, Portugal, 16%. So, we're talking about a 2 to 3x difference in the amount of investment in primary care. And we're seeing it in the outcomes. So this seems to be screaming out, at least to me, that we do need to invest in primary care a lot more here. We've got aging populations, we've got increases across all these non-communicable chronic diseases, as we call them, heart disease, diabetes, cancer, obesity, etc. And there is a solution, a highly scalable solution here that is very well studied, very well researched, is proven to address all these key things around quality, access, equity, short-term health, long-term health, but we're not investing in it. And I think that's really important.
You should scream that from the mountaintops. I agree with you 100%. I mean, we have such great examples as you're demonstrating here of what other countries spend in their outcomes. And just think of it, more than 10,000 people every day in the US are turning 65. So the needs are exploding because obviously as you age, you get more chronic conditions, you need more overall care, but you need more primary care. So policymakers need to listen, payers need to listen.
Excellent. Thank you so much for joining me for this one, Sanjay. Look forward to our next episode on longevity and primary care. Please tune in for that one, guys.
Thanks so much.